costs when people are sick, as well as the indirect costs of lost productivity when people have to stay home from work because they're ill. That is also a huge impact on society. So we frequently, when we think about foodborne illness, most people think that it probably wasn't something that occurred in their home, that it was probably due to them eating food outside at a restaurant or somewhere outside of their home. But when we look at actually trying to attribute the proportion of foodborne illness due to food prepared at home, it's not very easy to do. There have been some studies that have found that GI illness, which could be due to food, water, and other factors, does seem to be more associated with food cooked at home, or exposures at home, which could be food or water or other things. And in Europe, for example, most foodborne outbreaks are actually due to food consumed in people's homes versus outside the home. But as I said, most people actually think that if they got sick, that it's due to eating somewhere else, such as a restaurant. And additionally, this is often referred to as optimism bias, so they don't really believe that their practices at home are going to make them sick. So there's been a number of different qualitative research studies that have been conducted to look at look more at consumers' perspectives of safe food handling. So why do they engage in safe food handling, or why do they choose not to? And these are types of studies which would include things like focus groups, consumers, and sometimes interviews with consumers as well to understand some of those factors. And why qualitative research? Because open-ended types of questions where we can get people to explain in their own words why their experiences with those, their opinions, and we can get some more information using those methods than what we could with more closed-ended questionnaires and surveys where we're giving more predetermined types of answers. So it's more of an exploratory approach. And what we were trying to do with this study that I'm talking about today is can we understand some of the themes that have been found in some of those qualitative studies to try to pull out some of the common trends in the literature in terms of what consumers are saying is affecting their practices. So a couple years ago, when I was working for a Public Health Agency of Canada, we were doing a larger systematic review study to look at the effectiveness of food safety education interventions for consumers. And those results were published in 2005, or 2015. But as part of that review, we had captured some of these qualitative studies, and we wanted to have a closer look to try to pull out some of those themes. So that's where the rationale for this project came from. So I'll just briefly talk about our methods that we used for this. So what we were looking at was we wanted to find studies that looked at adult consumers because we felt that the factors affecting what adults do might be different than those less than 18 years old. So we just focused on adult studies looking at adult qualitative type of study that had to be published in English, French, or Spanish languages. And then we had to do a systematic search to identify these studies. So as I said before, we had done this previous review, which had captured a number of these. So we had already an updated comprehensive search and bibliographic databases online to identify some more relevant studies. We also looked on Google and hand searching some of the reference lists of these articles to make sure that we didn't miss any important studies. So we used a structured systematic review approach to go through this list, and the other reviewer, Lisa, we both screened all of the references we found to see if it was relevant or not, and then extracted information from those articles about their methods and what their results were, And we also assess the quality of the qualitative studies. And this is something we actually found a couple of previous quality assessment tools, and from there obtained 8 different criteria that we used, which could be used to assess how reliable those studies are. And then we did a qualitative synthesis of the results. So we basically read through the results section of all the articles we found, and then we did a coding approach where we read each line of the study and developed codes, which we then organized into thematic areas, which I'll go through as we go through the presentation. And we had classified these into 2 types of themes. One were descriptive, so we were trying to pull out the trends across the study. And then what we called more analytical themes, which were basically our overall hypotheses. Once we put everything together, how can we try to explain consumer behavior? So I'll talk a bit more about those as we go through later. And then also, we pulled out specific, what we call barriers or facilitators, motivators for safe food handling. And for each of those, we rated how much confidence we could place in, from low, moderate to high, based on something called a SIR-Qual assessment, which is a formal approach where we consider how many of the studies were finding the same thing. If only a couple studies found some factor, then we put less weight on that. We would have less confidence in that. And also, what were the methods, were the quality assessment rated high or low? That would also factor into this, as well as some other factors. So just to give you an idea of the approach we used, we had screened about 1,000 references that were considered possibly relevant to this topic, and ended up with 39 articles, so different journal articles or other documents. And in there was 37 unique qualitative studies that we analyzed. And we identified from these studies 6 groups of themes, which I'll go through. And within that, 21 specific barriers to safe food handling and 10 motivators or facilitators, and then 3 overall kind of analytical themes. So just to give an idea about where the studies come from and what were their characteristics, the vast majority were done in the United States. And they mostly used focus groups. So they would be studies that did several focus groups with different consumer groups to look at their experiences or perspectives on safe food handling. And they actually, in terms of the participant, there's a good cross-section of targeting different at-risk groups. So there was a number of studies looking at older adults, which are more susceptible to illness, pregnant women, ethnic and racial minority groups, caregivers of young children. So we did get a good there, as well as general populations of consumers. And in terms of the quality assessment approach that we did, we found that the major issue with these studies was that a lot of them didn't really describe how they analyzed their data. They just said that that themes emerged from the data, and something very vague like this. So because of that, we didn't really have a lot of confidence in some of those studies in terms of how they actually analyzed their qualitative data. And surprisingly, also, a few studies didn't mention anything about ethics. So they didn't mention that they had sought ethics approval or that they given information, which is pretty standard in most research with human participants. So now I'll go through some of the individual findings and try to explain some of I'll highlight the ones that we rated more as moderate to high confidence and focus not really as much on the ones where we had less confidence. So the first one, the first group descriptive theme that we call is called confidence in perceived risk. And under this, we found a number of barriers and facilitators to safe food handling. The first one is that many consumers don't perceive that they're at risk of foodborne illness due to cooking at home because they have a high confidence in their practices. And on the slide, you can see an example of one of the quotes from one of the participants in one of the studies where in terms of cooking meat and using a thermometer, they don't feel that they have to do that because they rely on their own intuition and tasting, texture, and other factors to assess whether the food is safe or not. So this was coming up frequently for many different types of food safety behaviors. We found that there was a belief among many consumers that they're more at risk of getting foodborne illness if the food is prepared by someone else. So whether it's one of their friends or eating out in a restaurant where they don't have control over the practices, they believe that they have a higher risk versus when they prepare their own food. And again, that ties into their confidence in their own practices and just not knowing basically what other people are doing with their food. We found that consumers were often indicated that they weren't concerned about foodborne illness due to preparing food at home because they've never experienced foodborne illness. So, and this frequently came up among in the studies of older adults. As you can see in the quote on the slide, they say that they've never gotten sick from doing a certain practice, such as maybe leaving food out in the danger zone past the recommended time or other factors. And so why should they change their practices? And I have the same issue. My father-in-law, or soon-to-be father-in-law, when he likes to cook his burgers raw, basically, and in the middle, and we always get in an argument about it, and he always says that, well, I've never gotten sick before, so why should I change my practices? So this is frequently thrown around as a reason. Another factor is the confidence in the food system, and we do have a safe, relative to many countries, food supply in Canada, but many people felt that I should, if I go to the grocery store to buy meat or other foods, I trust that the system is providing safe food, so I don't need to then worry as much about doing food safety in my own home because the food that's provided to me through the food system is of high quality. So this is sometimes used as well as a reason for why people don't practice safe food handling at home. The next theme was what we called, this is still part of confidence perceived drift, but this is people's motivators to safe food handling. So the first one is that many people indicated a concern for their dependents, such as their children or elderly family members, as a reason for why, or as a potential motivator for them to practice safer food handling at home. So they indicated they'd be potentially willing to change their practices if they were preparing for their children or for someone who is sick, but they wouldn't use those same practices if they were just preparing food for themselves. So that could be potentially used as an education target where we could try to basically leverage people's concern there in terms of trying to change practices. We also found that belonging to certain high-risk groups did increase people's willingness to change their behaviors. So, and this was particularly true among first-time pregnant women and immunocompromised people. They would be indicate that they actively would seek out information about safe food handling practices. They were interested in knowing which types of foods they need to avoid and what types of practices they need to change. So this also could be an area where we could potentially do a better job to try to educate these consumers when they're looking for that information. Because one of the factors within the pregnant women studies was that, for example, many pregnant women indicated that they looked to their doctor for advice. They wanted to find out about what to do for safe food handling, but their doctor didn't provide that information, so they indicated some frustration about that. So they had to go online or do their own work to actively look for that information. Some people were also concerned about their cost and inconvenience of foodborne illness as a potential motivator. So, for example, if we're talking about parents of young children, the fact that they would have to then stay home from work because they're sick, and the inconveniences of that in terms of who has to then take care of the kids, and things like this could be used as a potential motivator, and people in that way could be used to try to increase their safe food handling. So the next theme of different facilitators is what we call knowledge-behaviour gap. So within this, we found that there is a lack of knowledge and misconceptions about many safe food handling practices. So for example, leaving food, or what is the correct amount of time that you can leave food out in the danger zone. Many people didn't know that in many of these studies, as well as what their refrigerator temperature should be, the cooking temperatures of foods, and other things like this as well. So lack of knowledge is something for some of the practices. In addition, many consumers disagreed with some of the recommended safe food handling practices because it conflicted with their beliefs or perception, and this also contributed to their high-risk practices that they used. In addition, we also found that even though in some cases consumers were using, or they knew about what the correct practice should be, but they still followed the unsafe practice anyways, which just highlights that having knowledge, well, it's necessary that they know what the proper steps should be. That doesn't mean it's sufficient on its own in order to change people's practices. So, for example, some people indicated that they did know that they shouldn't leave food out to thaw on the kitchen counter for the whole day, but they still did it anyways for whatever reason. Either they disagreed with the practice or they'd never been sick before from doing it, from a number of different reasons. And we did find that consumers do follow, or they indicated they follow several recommended practices, such as cleaning and sanitation of utensils and countertops. But they often did this not with food safety as the main reason, but more just as a general common sense kind of practice, or trying to maintain general hygiene in the kitchen. The next theme we found was what we called habits and heuristics. And here we found that many food handling behaviors for many consumers are often routine, unconscious types of activities. They're influenced by their past experiences, so how they learned to cook maybe growing up, and as a result, they're very difficult to change. So this was a major factor, I think, contributing to some of the unsafe practices. People just, especially when they're cooking the same types of meals that they normally cook, they don't really actively think about it. They just do the practices that they're used to doing. It's only when consumers are cooking new recipes, maybe, when they might be more actively thinking about the practices they're doing, or when they're cooking for large events, such as a large family gathering, they might be more likely to use a thermometer to check the temperature of the turkey or the chicken versus just their normal everyday cooking. And they also use various rules of thumb to identify when food is safe. So many people, they don't use the thermometer to check tenderness of meat. They check the texture of the meat, the color, their own senses, and they often use those practices as well when they just to determine when a food is expired in the fridge. They don't consult the recommended times of keeping leftover foods, but if it smells bad, looks bad, then it's probably unsafe to eat. The next area is what we call practical lifestyle constraints. And here we found a number of factors. So the first is that often just the inconvenience of safe food handling or lack of time, laziness, negligence was a factor. So especially for busy people who They have to come home and quickly prepare food for their children, who then go off and do activities. They indicated they don't have time to then think about trying to use the thermometer or doing other practices that don't fit into their normal routine. So that was a factor for many people. In some cases, consumers indicated that distractions such as having kids in the house or messing around with the refrigerator was something that contributed to their unsafe practices, or having pets in the kitchen, making it a riskier environment. Consumers also indicated that they sometimes lacked proper resources and tools. So they indicated they don't have a thermometer, or they might have a thermometer somewhere buried in one of their drawers in the kitchen, but they don't know where it is, or they couldn't be bothered to look for it. And also some consumers indicated they don't have enough space in their refrigerator or freezer to do proper cooling practices and storage practices. And some people don't also have a dishwasher, which would facilitate sanitation of the utensils. In terms of facilitators, many consumers did indicate that they would be willing to change their practices if some of these barriers could be removed. So if you could convince someone that by using a safer practice, you would actually help to save them time. So maybe using a thermometer to check the doneness of meat would actually help you to get your meat ready quicker than you thought you could if you didn't use one. That could be used as a potential motivator for people. The next theme that we found was called food preferences, and here we found that many consumers, their food choices are often driven by quality of the food quality, the perceived health benefits of the food, and convenience rather than food safety. So this was often the case for consumption of high-risk products like raw eggs or undercooked meat. Some people just prefer the taste of those products, and food safety is a secondary factor there. And finally, the last theme we found was what we called societal and social influences. And here we found that in some cases the cultural traditions of people's backgrounds contributed to certain unsafe practices. So for example, with Hispanic communities, there's a tendency to consume raw milk cheeses. And again, this is driven by kind of cultural traditions, as well as some studies found, for example, that Asian consumers would frequently go to live poultry markets to obtain their meat, which again could be a higher risk type of practice. As well, unsafe practices frequently learned through family, friends, and social networks. People are growing up and learning how to cook. Those kinds of practices are being transmitted to people and kind of ingrained into their consciousness and the way that they normally will then practice safe food handling, which will continue on through their life. In terms of facilitators, I mentioned before for pregnant women, but as well in general, many consumers indicated they would look to healthcare providers for advice about food safety, as well as extension services, which is this is something from the United States. They have federally funded extension programs, which they work for universities, but then they work in different communities across the U.S. for different low-income communities, and they provide workshops and advice for low-income communities about nutrition, food safety, and many consumers indicated that they had high trust in those extension personnel in terms of looking for advice about food safety. As well, media was sometimes indicated as something which could increase awareness of food safety during high-profile outbreaks and things like this, but then some consumers also indicated that they would be annoyed sometimes by media in terms of the overhype or hysteria associated with food safety. So I mentioned before, we also developed what we called analytical themes, and these were basically we try to put all this information together into some, what are some hypotheses about how consumers' behaviors are driven. And the first one is that we could view safe food handling as part of a complex sort of interaction of everyday consumer practices and habits. So consumers, again, they don't actively think about what they're doing if they're preparing a food that they've normally prepared. It's part of their natural daily activity, and it's an unconscious type of behavior. And also their confidence factors in. So if consumers have high confidence, they have high confidence in their practices, and they don't really feel the need to change. Many consumers are not really concerned about food safety, and they're generally not motivated to change their behaviors based on new knowledge. So although we did find some areas where consumers lacked some knowledge or they had misconceptions, they often also did know what the correct practice should be, but they didn't bother to change their practice, or they weren't motivated to change. The exception to this was some of the high-risk groups that I mentioned. So first-time pregnant women, particularly, and immunocompromised individuals would be actively seeking out information about food safety. And also relevant social pressures can have an impact on consumers' willingness to change. So their concern for their dependents, for their children particularly, could be a motivating factor. And some consumers also indicated that they would be willing to learn about if their kids brought home information from school about food safety, that could potentially influence their own practices as well. So what are the implications of what we found? So there's something called social theories of practice, which basically say that for types of unconscious behaviors like food safety or food handling in the house, where it's an unconscious routine type of activity, to encourage behavior change, you need to instill new habits, new routines by creating a new norm. So how could you do that? You could take people out of their normal kitchen environment and maybe take them to an on-site workshop somewhere where they actually do hands-on type of training to learn about what are the different safe food practices. So maybe get them to prepare some different recipes where you integrate food safety practices within those recipes. And I mentioned those extension programs in the USA. There's a couple that are called FNAP, Expanded Food and Nutrition Education Program, and SNAP-Ed, Supplemental Nutrition Assistance Program, which they do this kind of thing. They do workshops with targeted groups of consumers and low-risk or low-income communities where they have them do these types of in-person workshops. And research has shown that they are effective to increase behavior change. In Ontario, the closest thing that I think that we could have would be in terms of the work that public health units do. And from my experience, it's mostly focused on food handlers who work in the food industry. So there could be an opportunity for health units to actually increase their activity just with our consumers in terms of their at-home practices. It's possible that some health units do this, but this could be an area where we could focus more, not just on the food handlers who work in the food industry, but also consumers in terms of what they do in their own homes. Also, we could try to target young adults and children because they're still developing their habits, so they might have more opportunity to change those. And we did identify a couple of young adult studies, and the young adults also indicated, so college, university type age students, they also indicated more of a willingness to change their behaviors than the older adults. So that could be an opportunity, as well as targeting those who are undergoing a change in health status or living situation. And there's been many different innovative interventions developed for these groups. So for example, there's Ninja Kitchen. I don't know if anyone's heard of that. It's an online video game for high school kids or children, basically, to learn about food safety, but kind of make it more of a fun experience. Different apps have been developed, and then even this group out of University of California has developed music parodies the popular pop songs and basically change the lyrics to be instructional about food safety. So there's different types of approaches that could be effective. So it would be interesting to learn at that in Ontario to see if we can find anything that might be promising. We could also try to focus rather than trying to just transmit new knowledge to people in the education interventions or educational campaigns, focus on some other factors such as, if you use the food thermometer, you'll save time, or you might end up with a better quality, better tasting product than if you didn't. So you'll avoid overcooking your meat or something like this. Those types of messages could be motivating for people. Or to try to change social cultural norms through more innovative approaches such as photonovella, which is kind of like a comic approach to a fact sheet rather than just putting out the information. Or edutainment. This is a term that's used for basically TV programs that they have narratives. They have a story with different characters, but within that story there's ingrained public health messaging, which actually is teaching people about safer behaviors. So they have this for safe sex education. They have programs like this. And it seems to be effective in that area, so maybe it could be something to look at for food safety as well. And then engaging healthcare professionals, I think, for example, doctors, could they refer newly pregnant women to different resources, maybe where they can get more hands-on type of training in terms of safe food handling in their home, rather than just giving them a fact sheet and say, go read this at home. So this slide, you can just see an example of what's called photonovella type of fact sheet that was developed for the Hispanic community in the United States. And it basically just explains why you shouldn't wash your chicken to prevent cross-contamination, but it does so more in a comic book type of approach that might be more appealing to consumers rather than just giving them another plain fact sheet. So that's basically all I wanted to cover today. I just want to thank a few people, the library staff for help with this review, some funding I received from Ryerson University, the Public Health Agency of Canada for in-kind support. And then we have written up a paper on this study that we've submitted to a journal, so hopefully that will be coming out soon as well. So thanks everyone for taking some time out of your lunch to listen, and at this point, be happy to take any questions.
Just give us a moment. We're going to pull up the chat pod here. I'd like to thank Dr. Young. Interesting research that you're doing there. If I could please ask those people that are in cyberspace, if you could, in the chat pod, indicate how in the room with you. This helps us track how many participants we have in this new series. We would appreciate it. And for those people that are online, if you could write your questions in the chat pod, I'd appreciate it. We'll start here if there's any questions in the room that anyone has for Dr. Young. No questions here in the room? So let's go online. While people are ready phrasing their questions, perhaps I'll start. I'd like to mention that Dr. Young, your presentation is very timely as we approach the Christmas holidays. CIPHI is going. We are recording this session. We're going to post it to our YouTube channel, and then I'm going to have that play on a loop for my in-laws as well, so that they can get a better sense. But perhaps in the meantime, can you describe how to approach overcoming the food preparation ego, the overconfidence of food handling skills? Like, how do we address that?
That's a difficult question, I think. Again, it might be just, taking people out and kind of showing them maybe real-world type of examples of how those unsafe practices actually can lead to foodborne illness. And then just maybe showing them how it's easy for them to change. It's not difficult. If they can practice doing it a different way, maybe that will help them see, oh, well, I could do it the safer way and it really doesn't affect me. And I'm still preparing food safely. So I don't know. I think just trying to give them more maybe hands-on type of experience or showing them real-world types of examples of how those practices that they're currently using, how they actually could lead to foodborne illness or other health consequences.
One of the health units that I was at had very good informational material. It was a chart printed with what the temperature of each particular type of meat should be. And what I did one year is I put that in with a meat thermometer that I purchased into stocking stuffers. And I found that my family members actually do refer to that now. They have the chart posted in there. So that material that public health units do produce can be very valuable educational material. It's just a matter of getting it distributed and getting it out there. In the meantime, Shannon has a question about how many of the studies identified the theoretical framework in how they assess the factors.
Hi, Shannon. Thanks for listening. So I did have a chart on earlier in the slides, but I didn't mention it verbally. But very few of the studies actually had a theoretical framework. So they just said, we're going to do some focus groups, and that's it. They didn't really describe what their approach was to analyzing it. So for that reason, some of the findings were, we could be a little bit less confident in some of those studies. So that's an area, I think, this whole area of the literature, there was some holes and gaps in terms of how they actually reported what they did.
Allison has a question. If you could talk more about CIRCWL, what factors are used to determine quality?
Yep, so that approach has 4 factors. One is what was called adequacy of the data. So this one, it took into factors like, it took into account things like how many studies found the same factor, did the studies give quotes from participants to back up their findings, or did they just summarize it in their own words and did they provide an in-depth summary of the data, or did they just provide a cursory or very brief kind of description? So if they didn't really provide a lot of depth, then we would have a little bit less confidence in those. It also took into account the quality assessment rating that we did. So were they reporting key features that they should be reporting? It took into account, were studies finding conflicting results? So did one study find one result and the other found the opposite finding, or were they mostly consistent? So it took into account that as well. And did it address our research question of interest? So were they talking just about food safety, or were they also talking about nutrition and other factors that maybe weren't the focus of what we were trying to look for here? I could, if you were interested, I could share you more information about that approach afterward.
One of the things that I was writing down as you were speaking there during your presentation, and the effect that PHIs have on the confidence in the food system, and this belief that the public thinks that there's a high-quality food system. I'd be curious to know about the inspector's influence on this confidence factor, and if that fluctuates at all during times of outbreak or recall, and then if you could compare that to those jurisdictions like where the daily activities of public health inspectors are a little bit more obvious, and particularly with respect to the inspection disclosure system. It'd be interesting to see the influence that has on the public's confidence.
Yeah, and just in terms of that, I guess, as I mentioned, some consumers did say that if they read about or heard about food safety in the media, that might make them more aware, at least temporarily, of their own practices, or more self-reflective of things. So, and we didn't really cover disclosure systems in this, so I'm not fully up to date on what that literature is saying, but it could be that those are also, could be prompts basically for people, and that could provide more, prompt about food safety when they're eating out. But in terms of what's happening in their homes, I'm not sure, unless they're getting it somehow kind of, maybe if they have something displayed on their fridge, they constantly see it as a reminder. That could be another way to try to increase the reminders for people about certain practices.
Any questions in the room? Back online. Shannon again is asking about how you, I'm sure everyone can see the question there, how you disentangle different factors are important in different populations versus concurrence of findings across studies gives confidence.
So there were different groups of, so we sometimes found that certain factors, for example, were seen more among older adults or studies in older adults, but we didn't really see those same things coming out with younger adults. And I guess we're a little bit limited because there weren't that many studies that focus on the, I mean, some studies focused, we had a handful looking at older adults and maybe a handful looking at pregnant women, and then a number also looking at general population. So I think we are a little bit limited in our ability to make some more distinctions between some of those groups. So it would be good, I think. I think there's an opportunity to do some more work in that area, especially in Canada. I think there was one study looking at pregnant women out of British Columbia, but other than that, most of the studies were done in the U.S. and a few in the U.K. And I forgot to mention earlier, we did focus on developed countries, so just the countries where they might have a similar type of food system as Canada. But I think there could be more work looking at some of these different groups and whether they have sort of unique factors that affect them differently than the general population.
Thanks, Ian. Just give another chance for folks to frame any last questions that they may have. It seems like things may be wrapping up, and during that time while you might be trying to get your last question, I'd just like to do some CIPHI Ontario housekeeping. This webinar series is a joint effort between Public Health Ontario and CIPHI Ontario, and we appreciate all of the principals that helped develop and deliver this series. We'd also like to thank all of those people that participated in the needs assessment surveys. We received about 500 responses. We're taking a look at the data, and we'll be able to feed that back to the health units and the inspectors out there. Give us a little time to do that, but we do appreciate you participating in that survey. We'd like to also thank all of those people that attended our annual conference and AGM. It was a great conference. We hope to see everybody next year in